All right, welcome everyone. We are pleased to be here and presenting to you this session titled Oxygen as a Drug. Please allow me to introduce our speaker. This is Dr. J. Paul Rogers. He is a wound and hyperbaric physician with UPMC in Central Pennsylvania. He serves as the regional medical director for the region and as the chief hyperbaric oxygen medicine for UPMC Pinnacle. Dr. Rogers graduated from Loyola University in Baltimore and the Medical College of Virginia. He is board certified by the American Academy of Family Physicians, Undersea and Hyperbaric Medicine, American Professional Wound Care Association, and the American Board of Preventive Medicine. He is licensed to practice in Pennsylvania and Maryland. Prior to devoting his career to healing wounds, he served as a physician in the emergency department of Pinnacle Health, Washington County, and Lancaster General. He teaches a regular rotation of emergency, internal medicine, general surgery, family practice, and podiatry residents. Dr. Rogers and his wife Juanita have 2 children, Jessica and Joshua. In his spare time, he enjoys fishing, cooking, and watching the Baltimore Ravens. Dr. Rogers.
Okay. Thank you very much for having me, and a quick shout out to UPMC Central WOCNs and nurse practitioner. Whoop. Thank you. Thanks for coming. First things first, I have no disclosures and I have no conflicts of interest. Okay, let's talk about a topic that's kind of near and dear to my heart, and that's hyperbaric oxygen therapy, oxygen as a drug. Gotta get my glasses. Don't get old. There we go. Okay, the Undersea and Hyperbaric Medical Society defines hyperbaric oxygen therapy as an intervention in which an individual breathes 100% oxygen at increased atmospheric pressures. By convention, clinical or therapeutic hyperbaric oxygen treatments are at 1.4 atmospheres or higher. This differentiates the clinical hyperbaric treatments from the so-called soft chambers that you'll see that are used for acute mountain sickness, but that a lot of people have in their homes. Generally, 1.4 is about the limit for those types of oxygen delivery devices. Exposing isolated body parts to 100% oxygen at pressure does not constitute hyperbaric oxygen therapy, according to both UHMS and CMS. Oxygen is a drug. It does have an order. It does require me to do an order when we do a hyperbaric oxygen treatment. The chamber is just another delivery device. It's not different than nasal cannula or non-rebreather. It's just the device that we use to deliver the oxygen. I promise you that we're not going to make you review high school or college physics. If this brings back bad memories, I'm going to get off this slide pretty quick. But these are all relevant to what we do in the hyperbaric chamber. I will mention them periodically as we go through this. I've kind of divided this into 2 parts. The first part is going to be the pharmacologic effects. So why do we do what we do? What is it that hyperbarics is doing in your body that we're taking advantage of? And then in the second part of this, I'll try and relate that to specific disease entities that we treat and what affects hyperbarics, which one of these effects is applicable to that disease entity. So it has anti-ischemic effects, kind of self-evident. If you were placed in an exceptionally high iron oxygen environment, that it would improve ischemia. And we are in exceptionally high oxygen environments. When you look at hyperbaric oxygen therapy compared to other delivery modalities, we deliver many, many, many more times than even being in an ICU on a ventilator. We can get PaO2s over 2,000 for those of you who do arterial blood gases or look at those. So we're talking exceedingly high quantities of oxygen by this delivery method. Neovascularization, which is the primary effect for things like diabetic foot ulcers and radiation injury, that are some of the things that people are most familiar with what we do treat in the chamber. It has antibacterial effects, vasoconstrictive effects, ischemia reperfusion injury, and gas bubble reduction. And yes, too much of a good thing can be a bad thing. And even with all these wonderful things that I'm going to tell you about what oxygen can do for you, you can also become toxic from it. And we will talk a little bit about oxygen toxicity as well. Okay, so when we start to talk about improving oxygenation. This is a schematic, and what you see on the left is capillaries in the perfusion zone of the capillaries under normoxic or normal oxygen conditions, so 21% at sea level or 1 atmosphere. And you can see that the diffusion is about 64 micrometers. Under hyperbaric conditions, you can see that increases by about 4-fold. And if you take a look on the left, you can see that little area that they have labeled ischemic zone. Now, this is a schematic. It's not what really anatomically happens, but you get the idea that if you're in that ischemic zone and you're under normoxic conditions, you're not getting enough oxygen. And simply placing you under hyperbaric oxygen conditions, that same area of tissue is now very richly oxygenated. Neovascularization is really two different processes. The first one is angiogenesis. This is development of new blood vessels off of existing blood vessels. So these will be blood vessels that are on the periphery of your wound. And under hyperbaric oxygen conditions, we can stimulate those blood vessels to branch off and create new blood vessels that extend into the wound. The second process is vasculogenesis. This is a completely different process. Hyperbaric oxygen therapy stimulates the release of vasculogenic stem cells from the bone marrow. And these vasculogenic stem cells, in the right circumstance, and the center of a wound would be the right circumstance, can differentiate into vasculogenic and actual vascular tissue. So this is de novo synthesis of new blood vessels within the central aspect of the wound. And this is stem cell dependent. And there's some fairly good research out there, some of it done right here in Pennsylvania, that shows that hyperbarics increases stem cell release into the bone marrow. So this is one of the methods that we employ when we develop new blood vessels, in particularly things like diabetic foot ulcers, but also with radiation injury wounds. Antibacterial effects, particularly anaerobic bacteria, can be bactericidal or bacteriostatic. Usually bacteriostatic, meaning the bacteria just doesn't like that high oxygen environment. It doesn't kill it, but in that environment, it doesn't reproduce. It's relatively stunned, and it becomes metabolically inactive. This will be important when we start to talk about gas gangrene and C. perfringens. In certain circumstances, it can actually be cidal and kill the bacteria as well. Our defense mechanisms are largely O2 dependent. Neutrophils use oxygen for killing, O2 radical species in particular. And when you enrich the oxygen supply for the neutrophils, or more importantly, get it back to a normal level, they become much more efficient killers, thereby much more effective in terms of clearing bacteria from the wound. Macrophages also are enhanced by elevated oxygen levels. Enhanced antibiotic transport, we don't really use gentamicin much anymore, and aminoglycosides really aren't used like they used to be, but they are O2 dependent for transport across a bacterial cell wall. So if I remember the Amp-Gent and Clinda days. That was a long time ago. Some people might think that's a music band now, I'm not sure. But actually we used a lot of gentamicin a long time ago. It has some toxicities. The cephalosporins largely replaced it. There's some evidence the cephalosporins are enhanced as well with elevated oxygen levels, but generally it's the aminoglycosides. It's an old graph, 1984, but I think still relevant. And what it shows is the clearance of Staph aureus from a wound as the oxygen levels are increased. And you can see a normal tissue for us is 50-55. Most of our diabetics are not hitting 50 or 55, but you can see, particularly in that range, the steep part of the graph where you're getting much more efficient clearance of the Staph aureus from a wound as your oxygen levels are improved. Vasoconstriction. So elevated oxygen levels lead to decreased blood flow and vasoconstriction. You have the ability to auto-regulate. And examples would be if you eat a big meal, more blood flows to the gut. If you're exercising, more blood flows to your muscles. And your body can auto-regulate within a certain range how much blood flow is delivered to a tissue. So if every tissue in your body is completely saturated, then what message is going to the arteries is, whoa, slow it down, cut down the flow, tighten up. And so we can reduce by about 20% blood flow to a tissue. This becomes important with things like ischemic reperfusion injury, and it also matters with things like flaps and reconstructive flaps, where they become edematous, they become venous engorged. That impedes blood flow in. If we can prevent them from being hypoxic, but also reduce the amount of blood trying to be delivered to that tissue, we can lead to improved oxygenation and healing of the tissue. This is also why your hyperbaric doctor is going to ask you to get an echocardiogram before we put somebody in the chamber. And that's because your heart has to be strong enough to push the same amount of blood through these tighter pipes. So as every single pipe tightens up, your heart has to be strong enough to get that same volume back around through those tighter pipes. That's why we ask you for an echocardiogram. We like an EF of at least 40% if we're going to put you in the hyperbaric chamber. Multi-place chamber, a little bit different. Those are the ones that look like giant submarines in the basement of a hospital. Most of what we use in wound centers are monoplace chambers. The multi-place chambers, you can sit upright. So if you remember from congestive heart failure, you lay down flat, you get more short of breath. You've got a little more wiggle room in a multi-place chamber in terms of your ejection fractions. But in the monoplace that we use, you're fairly flat. You're on a slight incline, and 40% is really about the limit. Ischemic reperfusion injuries. There are several ways that we help ischemic reperfusion injury. Obviously, if you're ischemic and we give you oxygen, that'll be beneficial. We just talked about decreasing blood flow to the tissues, and one of the problems with ischemic reperfusion injury is that you get this cascade of ischemia, inflammation, adherence of neutrophils to the endothelial lining of the blood vessel, which causes leakage, which causes edema, which causes more ischemia, which causes more inflammation, which causes more adherence, and around and around and around you go. And how do we break that cycle? Hyperbarics increases nitric oxide levels in tissues, which interferes with a protein. Beta integrin is the protein. It interferes with the manifestation of that protein on the endothelial cells, which is what the neutrophil is adhering to when it adheres. So in addition to vasoconstriction and oxygenation, we also directly interfere with the cascade of neutrophil adherence to the endothelial lining and subsequent edema. Gas bubble reduction, both pressure and oxygen mediated. So the pressure component, Boyle's law, sorry, I had to say it. P1V1 equals P2V2. So if you have a bubble and your bubble is a certain size at a lower pressure and we increase that pressure, the bubble gets smaller. So by making the bubble smaller, we can move that further out into the vascular tree where it's likely to do less damage. They do get occluded in the capillaries. Obviously, the bigger the bubble, the quicker it gets occluded, and the more damage it does in terms of the amount of blood flow it was able to obstruct. If we can make that a smaller bubble, gets further out in the vascular tree, doesn't do as much damage. We also want to eliminate that bubble. And so one of the questions that I'll get sometimes on the phone is a well-intended ER doc who says, yeah, I have one of your hyperbaric patients and they've got this weird shoulder pain. Do you think they have the bends? And the answer is no. And the reason is because my patients are in a 100% oxygen environment. So when we put you into a 100% oxygen environment and this bubble is not 100% oxygen, it's got nitrogen in it, you're going to start to donate nitrogen to the environment. You're not in that same equilibrium state. So as you give up nitrogen to the environment, if 78% of that bubble was nitrogen, then you're going to give up a portion of what's in that bubble to the environment. So not only is the pressure going to make it smaller, but the resolution of the bubble, bringing it back into solution, is also going to go quicker because the equilibrium favors donating that inert gas that's in the bubble but is not in the environment that you're breathing. So it's those two mechanisms that are relevant to decreasing bubble formation or eliminating bubbles that have formed. The bad news: too much oxygen is toxic to every living creature. We use a series of protective mechanisms, antioxidant, hemoglobin to regulate how much oxygen is delivered, and vasoconstriction. But when you use the levels of oxygen that we use in hyperbaric oxygen therapy, it is possible to overwhelm the body's defense mechanisms. The primary tissues affected are nervous, pulmonary, and ocular. Pulmonary has unit pulmonary toxic dosages. There's very mathematical calculations. We stay shy of those. We don't have to worry about that. Ocular toxicities we also don't have to worry about. But the brain turns out to be a little bit of a trickier animal in terms of toxicities. There's really not a mathematical formula for CNS toxicity to oxygen. We do use treatment algorithms, obviously, that tend to keep us away from that toxicity. But if you do this for a living and you do it long enough, you will eventually see someone with a seizure. It does not seem like we can completely eliminate that risk. Manifestations, obviously seizure activity and loss of consciousness. Things that you might see prior to that: sweating, pale, apprehensive, twitching, nausea, vomiting, hiccups. But most of the time what we get is the dreaded, I don't know what's wrong with me, but I don't feel right. And there's a couple of ways that we can mitigate that. But the most direct effect is when people are in the hyperbaric chamber, we give them a face mask, and hooked up to that is just room air, 21% oxygen, not 100%. At a 2-atmosphere dive, I've never seen a seizure. It's very unlikely, and we don't have to give you what's called an air break. But at a 2.5-atmosphere dive, we do routinely give you air breaks, 2 of them, where we don't interrupt the treatment, but we have you pick up the mask and breathe regular air to decrease your oxygen level. So if you say something that sounds worrisome to us in the chamber, the first thing we're going to do is tell you to pick up the mask and breathe the room air. And if your symptoms go away, then we know you were getting oxygen toxic and we need to make adjustments. If they don't go away, we've still got to address it, but we know that it's not oxygen toxicity. Briefly, things that increase CNS activity increase your risk of seizure because they increase oxygen consumption by the brain. Things that decrease CNS activity have an opposite effect and decrease your risk of seizures. What if it happens? We're going to come back to Boyle's Law. I hate to do that to you, but we are. During the tonic-clonic phase of the seizure, you're not breathing. And if you're not breathing, you're not exchanging air with the environment. And if you're not exchanging air with the environment, and we decompress you, P1, V1, P2, V2, so now you have a fixed volume. Now we take down P. What has to happen to V? What's going to happen to the air in your lungs? It's going to expand. What's that going to do? Pulmonary barotrauma and a pneumothorax. And if I continue to decompress you, it'll be a tension pneumothorax because it'll continue to expand. So you have to sit on your hands and wait until the seizure is over, and that is the longest 5 minutes of your life. But you have to wait. Once you see that they're spontaneously breathing, you can then start the process of decompression. I've had it happen to me twice. Both patients did fine. Both of them came back and completed their course with some adjustments and treatment. But it does happen, and it is a very long 5 minutes. Okay, selected disorders. Questions now, that's just the basic science of the different things. I'll try and relate that now to the actual specific disease processes. And I guess we should talk a little bit before we move into this about why hyperbarics, right? Because one of the questions that I get over and over and over again is, why can't I just breathe a face mask? Why do I have to go into this chamber? Why not just sit here with the face mask and breathe regular oxygen? And the answer to that is because we're bypassing the hemoglobin molecule altogether when we do hyperbaric oxygen therapy. So if I put a pulse ox on any one of us in this room, 95, 96, means I've got a big 4 or 5% more on the hemoglobin molecule, which isn't going to make a big difference. But the other way you carry oxygen is dissolved in plasma under, I hate to do this one to you, but there is another law for this one, and I had to think for a second, but it's Charles. And it says that a gas dissolves into a liquid proportional to the concentration of the gas and the pressure of the gas on the liquid. So what are we really doing? We're driving oxygen into plasma. We're using plasma as an oxygen-carrying vehicle, or bypassing the hemoglobin molecule altogether. That's how we get ridiculously high PO2s that we talked about, and that's why you have to go into this chamber and be pressurized. That was a very interesting study by a Danish physician, Borima, who took pigs in a hyperbaric chamber. He did an exchange. He got their hemoglobins down to about 0.6 and had a combination of crystalloid and colloid that he infused to keep their vascular volumes sufficient, and the pigs lived. And the title of the paper was Life Without Blood, and what he showed was that he was able to dissolve enough oxygen in the liquid going through the pigs that they did not need hemoglobin or blood to survive until obviously the hyperbaric treatment ended, and then things changed. But it does show that we can get exceptionally large quantities of blood into the plasma, bypass the hemoglobin molecule altogether. What else does that do? Microvascular disease. Your red blood cells are usually bigger than a capillary. They're meant to be. That's why they deform and fold when they go through the capillary. But with microvascular disease, there's places they're just not going to get that the plasma is still getting. So that's how we get oxygen to places that weren't getting as good oxygen, not only because it's high, but also because it's in a medium that can get where the red blood cells can't get. All right. Adjunct and standalone therapy. We are standalone therapy for decompression sickness and arterial gas embolism only. Everything else we are considered adjunctive therapy, meaning there are other things that you should be doing than the things that I'm going to show you here today, in addition to hyperbaric oxygen therapy, to correctly and properly treat your patients. I would say to you, carbon monoxide poisoning, we should be considered primary, but the problem is it's the most common poisoning in the country. Most ERs are not going to have access to a hyperbaric oxygen chamber. And as soon as they made that standard of care, fully 80% of the ERs in this country would be out of compliance. American College of Emergency Physicians does not consider hyperbaric oxygen therapy standard of care for carbon monoxide poisoning. It's better than your other treatments, but it's largely access issues. I would also say that you should think about radiation injuries and delayed effective radiation. We'll talk more about that, but there are treatments out there that stop the bleeding, which you have to do, but hyperbaric oxygen therapy right now is really the only one that reverses the disease process. So those are ones I would consider. We're not primary for those, but I think we should be considered as a primary therapy for those. I'm going to do arterial gas embolism and I'm going to do decompression sickness together. Arterial gas embolism is when an inert gas usually enters the arterial circulation. It's usually a medical procedure, but there are other things like pulmonary trauma that can allow for a large quantity of air to get into the arterial circulation. Now, we've all seen bubbles in IV tubing, and we don't panic when that bubble goes through to the vein because the lungs scrub it out and the pulmonary capillaries capture that. It takes an awful lot of gas to overwhelm the lungs. That's usually no big deal and not a problem. But on the arterial side, it changes a little bit because where that bubble lodges is going to interfere with blood flow and is going to cause basically stroke-like symptoms. If that happens in the central nervous system, spinal cord or brain, that can be particularly devastating. 50% of these bubbles do not show up on a CT scan, and so it needs to be a clinical diagnosis. Decompression sickness, the best model for this is your carbonated beverage, right? So you've got this carbonated beverage, and you've got carbon dioxide under pressure, and the carbon dioxide is staying in solution. It's not bubbling. If you go diving, and we can get into partial pressures if you want, but you load up on more nitrogen at depth in your blood than your blood can hold if the pressure was lower. So what happens when we open up the top of the soda bottle? Carbon dioxide comes out of solution, right? We lowered the pressure, the carbon dioxide came out of solution. What happens to your diver when they go from 300 feet to 100 feet too fast? Comes out of solution. So that's sort of the same mechanism. So what do you do to stop the soda from bubbling? Put the top back on real tight, right? And then it goes back into solution. And what do we do with hyperbaric treatment? We send you back down to where you were before. So we put the top back on and we get those bubbles back into solution. But now what? Well, now if we slowly bring you up, sort of like you just turned it just a little bit, you're not going to get bubbles or you're going to get a few. And probably the reality is that most divers get a few. They usually don't go to the spinal cord or the brain. They may not produce any symptoms, but it's kind of hard to get that top perfect so you don't get any bubble. And then what do we do? Well, you're in 100% oxygen. So we talked a little bit about donating to the environment. So in this case, it's nitrogen. You're in a nitrogen-free environment. So not only have we made the bubbles smaller and hopefully sent them further out or actually pushed them back into solution, but now you're going to donate that inert gas to the environment while you're in the chamber. And as we slowly decompress you, we can usually get you back up to what we call surface and hopefully not have any further bubbling. So those are the two mechanisms for decompression sickness and acute gas embolism. Vessel obstruction, distortion, disruption. So they obstruct vessels. That's because they get to a point they can't go any further. They block it. Now, they've blocked it, and now you're coming up, and now they're expanding. So what? They can distort tissues, and they can disrupt tissues because the bubbles continue to expand. Carbon monoxide poisoning. Generally, the exposure for carbon monoxide poisoning is burning and a fire. The paint stripper was banned, so we don't really see that anymore. It's a clinical diagnosis that's based on exposure and symptoms. Most common cause of death in fire victims. Particularly headache, fatigue, dizziness, balance, hearing loss, neurologic complaints, myocardial injury, increased anxiety, and depression. That's called the delayed effects of carbon monoxide poisoning, and that's actually what we treat for the most part is the delayed effects. So the acute effects, the acute hypoxic injury, yes, I mean, if you think about what's happening with carbon monoxide poisoning, you've got a hemoglobin molecule, and it really likes carbon monoxide a lot better than oxygen. So if you give it the choice between grabbing a carbon monoxide or an oxygen, it's going to grab a carbon monoxide almost every time. So you're not dusky and you're not ashen, and you're actually rather pink and kind of nice. And if you put your pulse ox on, it's 100%. But the problem is you don't have any oxygen. They are completely saturated with carbon monoxide. That produces several problems. There's direct anoxic injury. You don't have oxygen. That usually is the heart. There's not a lot we can do about that because by the time you make it to the hyperbaric chamber, you've either reversed those cardiac conditions or they've had their ultimate effect. But the brain's a little different, and you get into ischemic reperfusion injury with the brain. You get into the delayed neuropsychiatric effects with the brain, and that's where hyperbaric oxygen therapy is beneficial. Treatment criteria, the numbers matter in that we'll say 25%, and if you're pregnant, 15%. Pregnancy is a relative contraindication to hyperbaric oxygen therapy. If you've got radiation injury to the bladder and you're pregnant, we're going to wait until you've had your baby, and then we'll treat you. But obviously carbon monoxide poisoning is not an option. And fetal hemoglobin has a higher affinity, meaning it would much rather hold on to carbon monoxide than adult hemoglobin. So we treat at a little lower number, 15% for that. But you can have a 3% level, and if you've got symptoms that are attributable, we treat. So if you've got focal neurologic symptoms and you come in at 5%, which might be a background level for a smoker, we're going to treat you based on your symptoms. If you've got ischemic changes on your EKG and you're at 5%, we're going to treat you based on your symptoms. So the numbers matter, but it's the symptoms that are more important. The studies are 6 hours. Kinwall was who did a lot of this, and his studies are 6 hours. And within 6 hours of exposure, there was benefit. When you got past 6 hours, that was somewhat questionable. From a practical standpoint, most hyperbaric centers draw the line at 24 hours, despite the fact that the data says 6. So if your exposure's been within 24 hours, we'll treat. If it's been more than 24 hours, we won't treat, which means we don't treat these chronic carbon monoxide cases where someone's been exposed day after day after day after week after week after week. Removal times. There we go. This is the big controversy in emergency medicine because, room air, obviously, you've got 320 minutes. Under 100% oxygen sitting in the ER on a non-rebreather face mask, 90. And under hyperbaric conditions, about 33 minutes. But then the question becomes, how long does it take to get you to the hyperbaric center? And so therein lies the controversy. If it's going to take 4 hours to get you to a center, get the tech in, get the doctor in, get the chamber up and running, probably don't need to transport, probably going to stay in the emergency room and breathe 100% oxygen with a non-rebreather. But if you happen to have a hyperbaric chamber downstairs beneath your ER, then that dynamic changes considerably. So that's one of the controversies in emergency medicine is to transport or not, depending on how quick you can get the patient treated. Primary mechanism of action here is actually mitigation of ischemic reperfusion injury. You would think it would be the anti-ischemic effects, and those have a role, but primary mechanism of injury here is ischemic reperfusion. So what happens here is you're ischemic, you've got the carbon monoxide. At some point that clears, you're now going to reperfuse, and then you get that ischemic reperfusion injury that we talked about before with the cycle. And the primary mechanism of action here is mitigation of the ischemic IR cycle. And the primary symptoms that benefit are the delayed neuropsychiatric symptoms. That's where we have the most success. We talked about removal times. There we go. I've never seen this. I'm 31 years in medicine. I worked in an ER for 17 of those, hyperbaric center for the remainder. I've never seen C. perfringens gas gangrene. I've seen necrotizing fasciitis a bunch of times. I've never seen C. perfringens. What's described is an advancing phlegmon that can move 6 to 8 inches an hour, exquisitely painful, sweet-smelling discharge. If you're going to do a gram stain, it's going to be gram-positive bacilli. Extremely lethal, and the primary mechanism is alpha toxin. The bacteria secretes an alpha toxin, which is a strong proteolytic enzyme that advances before the bacteria and basically liquefies the tissue that it's in. It's then followed by the bacteria who secrete more alpha toxin, more tissue damage. The bacteria follows on up a limb, on up a leg, and again, 6 to 8 inches an hour, so it can be fairly rapidly advancing. Traditional treatment for this was surgery, antibiotic, surgery, and these patients got a lot of debridements. There's good data out now. It's a 3-atmosphere dive. It's a big dive, and it's 3 times the first day. So it's a very aggressive hyperbaric treatment. But you do your initial surgery to get as much of the devitalized tissue out as you can. You start your antibiotics, and you start a course of hyperbarics. Once it's stabilized and fully demarcated, then you can do your definitive surgery and your definitive debridement to clean up. Mechanism of action. We talked before about anaerobic bacteria. This is an anaerobe. And we talked a little bit about bacteriostatic versus bactericidal. This is bacteriostatic. So what this does is the bacteria is incapable of continuing to secrete alpha toxin. It halts the advancing phlegmon, and then you have time to do additional hyperbaric treatments and let the antibiotic work before you do additional surgery. I've never seen it. And I don't know somebody who has. I'm sure it's around. I think it was around more in the past than it is now, but I've genuinely never seen a case of this. Selected problem wounds. What they mean by this is diabetic foot ulcers. You'll see in CMS guidelines selected problem wounds, and I've tried to argue a number of selected problem wounds for hyperbaric oxygen therapy, and the only one that I've gotten any traction on has been diabetic foot wounds. So when you see selected problem wounds, think diabetic foot ulcers. Currently, it needs to be a Wagner stage 3. I know there's other scales out there, and quite frankly, I think some of those scales are better. But the Wagner scale is married to hyperbaric oxygen therapy, and as such, we use the Wagner scale because of hyperbaric oxygen therapy. So a Wagner 3 is de facto osteomyelitis. And it's interesting, if you Google Wagner 3 and you look at the number of definitions for a Wagner 3 that come up with just a simple Google of it, it's kind of interesting. But probes to bone, exposed bone, but bone involvement in the wound. Diabetic foot ulcer, probes to bone, 85% chance you're dealing with osteomyelitis based on that statement. So a Wagner 3 is a de facto osteomyelitis. Standard wound therapy. So as hyperbarics has become more and more popular, and as CMS and other entities have taken a look at how much they're spending on hyperbarics and have made efforts to slow that down, we now have a clause where we have to do standard wound therapy for 30 days. And there has to be inadequate improvement over a period of about 30 days in order for us to do hyperbaric oxygen therapy. This is basically what's included in standard wound therapy. So vascular evaluation and addressing any problems, nutritional status, glucose control. They don't have to have perfect sugars. But if they don't, you need to be addressing that. That has to be addressed. Now, you're not going to get in at 500 a day. That's not really addressing it. They have to get improved sugars, but it does not have to be optimized. Debridement if necessary, infection control if necessary, appropriate wound dressings, proper offloading. When we say no measurable improvement, it's inadequate improvement. So and most of you have probably seen the slide that's in about every wound talk, where you want a diabetic foot ulcer to decrease by 50% in 4 weeks if you're on the curve and you're making adequate progress. So if you do this for your 4 weeks, your 30 days, and you maybe have a 10% reduction in the wound, that's not adequate progress. So that's sufficient to go forward. But how many diabetic foot wounds that probe to bone fail to make progress for 30 days and don't tank and have to go to the hospital? Not as big a number as you think. It's a pretty bad wound if it probes to bone, and it would be one thing if we were making progress, and if we are, well, then we don't do hyperbaric oxygen therapy. But we're not making progress, but we're not losing it bad enough to crash and burn. We're just losing it kind of halfway so that you're still in my wound center in 30 days. Not a lot. When they put this rule in, we don't treat as many diabetic foot ulcers as I think we should. The flip side of it is, you can't meet somebody for the first day, say, hey, that's a Wagner 3 and welcome to my hyperbaric chamber. That's not quite kosher either, but I think the truth is probably somewhere in the middle. Mechanisms of action for this is neovascularization that we talked about. Do the enhanced PMN function matter? Sure it does. But the primary mechanism of action is neovascularization and angioneogenesis. Those processes take about 20 treatments, and we've got to show improvement in 30 treatments under current guidelines, or in 30 days. I'm sorry, not 30 treatments. Now think about your weekends. 20 treatments is 4 weeks. So I've got just about enough time to show improvement, because if I don't show improvement in 30 days, we have to stop. So things have gotten kind of tight. And on average, it's 20. Some people might respond a little early. Some people might respond a little later. Some people come up to me after 5 treatments. They're like, Doc, this stuff is working good. And I'm like, well, that's good. It's probably not me, but I'm glad that you're getting better. Really, 18, 20, 22, somewhere in that range is where we're looking for the angioneogenesis to really start. You can treat at 2 or 2.5. We used to do up to 60. We've been capped now at 40. A typical course of hyperbarics is 30 treatments. And so we're looking for improvement around number 20. There'll be one of 3 directions that we go in. We're hitting it out of the park. 30 is all you need. We stop. We're wasting your time. We might not even finish the last 5, but we're not getting anything close to what we want. We're not going to continue on. Or we've done good, but we could do better. And in those situations, we can add additional treatments. For diabetic foot wound, we can add up to 10 more. So another 2 weeks. Neck fash. We have an indication for necrotizing fasciitis, and the indication is not just any case of necrotizing fasciitis that comes along, we're going to put in the hyperbaric chamber. Generally, there needs to be some impairment of the immune system or some impediment to wound healing in addition to just neck fash in order for us to get authorized to treat. And unfortunately, in our area, if you're on Novitas, they'll only cover this inpatient. We can't do it outpatient. So, and that's true for gas gangrene with C. perfringens as well. And that's really taken this out of our wheelhouse. But I have done a few cases. One was a neck fash case with Hep C and interferon and a white count of 1.8. So that did meet the extra criteria. That person did exceptionally well with hyperbarics, but it can be done on an inpatient basis only in our area. If you're outside the Novitas area, it's a different set of rules. Now, there we go. All right. Osteomyelitis. We do not have an indication for your first episode of osteomyelitis. Would we help? Yeah, we would. But 60 to 70% of the people are going to get better with debridement and antibiotics. And so there's not really a necessity for an expensive and time-consuming therapy like hyperbaric oxygen therapy when the odds are in your favor that you're going to get better. But what if you don't? So chronic refractory means it's chronic. It's been around for a while. Didn't respond to appropriate therapy, which we like to be surgical debridement and 6 weeks of antibiotics. Orals are becoming more popular, so doesn't have to be IVs any longer, but you're seeing more and more oral antibiotic being used for osteomyelitis as well. If it's sternal or vertebral, the debridement is not as important, and there's good evidence out there that antibiotics and hyperbarics can get you where you need to be. You start getting into long bones and out in the foot where the perfusion's not as good, and you really want that debridement. If you fail that, then there's an indication for hyperbarics. But it's not, oh, look, you still have osteomyelitis, let's go in the chamber. That's not, and I've seen that's not the way that this is intended to be done. You need another debridement. You need another round of antibiotics, and then we add hyperbaric oxygen therapy. There's not good human data for this. There's not good human data at all. And if you think about it, it would be hard to do. It'd be hard to get 200 people with Staph aureus in their femur all at the same time with the same comorbidities and the same perfusion. deficits or lack of deficits, and then divide them up and decide. But the animal models are pretty good. There's a good Staph aureus in the femur model for rats. And when they break these down into the different subgroups, by far, if you compare debridement, antibiotic, and hyperbarics, or what if I just do antibiotic and hyperbarics, or what if I just do debridement and antibiotic, by far the single most important determinant is debridement. By far, getting that infected bone out is the most important thing to do, particularly if they're refractory and have not responded to an initial course. Because each time you're refractory, the likelihood that you're now going to respond to the next course of treatment goes down and down and down. So if you didn't respond to the first course, it's less likely you're going to respond to the second. If you didn't respond to the second course, it's even less likely that if we do this a third time, you're now going to respond. And really, if you've done it 3 times and not responded, it's kind of crazy to think that a fourth go-around of the same thing is going to get you there. But if you look at those combinations, if you did antibiotics and debridement versus antibiotics, debridement, and hyperbarics adds about 13%. So it's not insignificant, but of the 3, it's the least important, which is why the proper way to implement it is repeat debridement, repeat antibiotic, and then do hyperbaric oxygen therapy. Mechanisms on this. Enhancement of PMNs, obviously anti-ischemic effects because infected bone is ischemic bone. But the big one turns out to be the osteoclast. And when I talk with patients about this, I liken it to an asphalt road machine. So you've got this machine that's ripping up the old road, and you've got this machine that's putting down the new road. The osteoclast is the one that's ripping up the old road, and that's what they do. They don't function well at all in a hypoxic environment. So if you've got infected bone and hypoxic bone, that primary mechanism of picking up that infected bone and reconstructing that infected bone is impaired, and they function much better in a normoxic environment. How are we doing on time? 3:40, right? So we're pretty good? Okay. We talked about that. Okay, this one. So if I wanted you to walk out of here, with one thing, it would be hyperbarics and radiation, hyperbarics and radiation, hyperbarics and radiation. This is our best diagnosis that we treat. And honestly, if we don't help this, I think you can make the case that we didn't have the right diagnosis. All tissues are injured by radiation. Anything that divides is vulnerable. The more quickly you divide, the more vulnerable you are, but any tissue is vulnerable. And the evidence for that is acute radiation dermatitis. You've all seen it. Patients are being treated with radiation. They get acute radiation dermatitis. That is not an indication for hyperbaric oxygen therapy. The acute damage from radiation is not what we treat. We treat the chronic and delayed effects. So in the acute phases, you release pro-inflammatory cytokines. TGF-beta is the big one, but there's others. And that's normal. But what should happen is once the insult has ended, then the release of pro-inflammatory cytokines is supposed to taper off and stop. And in some individuals, it does not. And so you have continued inflammation. And anytime skin is subject to long periods of inflammation, it falls back into fibrosis. And so when you see these venous leg wounds, they've been inflamed for 30 years. What do you get? Fibrosis, lipodermatosclerosis. The same is true with radiation. If they've been exposed to inflammation for long periods of time, they go into fibrosis. That fibrosis obliterates the microcirculation, not unlike a diabetic whose microcirculation is compromised. And so it's the same process of angiogenesis. The difference between a diabetic and a radiation patient is in radiation, that insult's over, as opposed to a diabetic who's still diabetic. So they're not having continued insult, but that's the primary mechanism. So your radiation cystitis is radiation proctitis. It's not just radiation of the skin. We have very good results on, particularly bleeding. Some of the subjective symptoms, maybe not as much. When they say, I kind of irritated when I void, it kind of bothers me. They're a little harder to treat, and I think it's because they're so subjective. But when you get a very objective criteria, like can you see blood in your urine, yes or no, we do very well with the more objective criteria. Particularly your patients who are getting clot retention, who are going into the ER or the hospital, or who need transfusions from the amount of blood that they're losing. These can be game changers. So your current primary therapies, stop the bleeding, and I'm not knocking that. So, your fulgurations, your Alum washings, things like that. If there's a hole in the dam, you do have to put your finger in that, and I get it. But who rebuilds the dam? None of those treatments fix the underlying disease process, and hyperbarics is the only one out there that actually addresses the loss of microcirculation and restoration of the microcirculation to correct the underlying pathophysiology, which is why I really think we ought to be considered as a primary therapy. That's where we have our most success. Mandibular osteoradionecrosis, same process, some very eloquent studies out there. Mandible absorbs 1.6 times more radiation than soft tissue. So when you're getting a head and neck cancer treated, the mandible's going to take a beating. If it's bad enough, it may break down on its own, or a lot of times they pull a tooth, and now you can't heal from having the tooth pulled. We used to have an indication for prophylaxis for that. We could treat before they pulled the tooth. I hear a lot of talk about preventive medicine, but when it comes time to pay for preventive medicine, they weren't quite in the mood to continue to do that. It's no longer covered. That's unfortunate. But now we have to pull your tooth and wait and see what happens. And then if you do get ORN, osteoradionecrosis, you have an indication for treatment. I'm going to, real quick, flaps and grafts. We don't really do skin grafts. In the old days, we had an indication for if you failed. So if you got a skin graft and it failed, then you would do hyperbarics to improve the granulation tissue, improve the wound bed, and try again. That went away. Just a graft, we don't. Flaps, yes. If they fail the pinprick test, right, you prick it, it doesn't bleed, that's arterial, that's not an indication for hyperbaric oxygen therapy, that's a mechanical occlusion of the graft, and you need to go back and get more surgery. But if it's purple, engorged, swollen, and you have a venous occlusion or partial venous occlusion, then you do have an indication for hyperbarics. Multiple mechanisms there, a direct anti-ischemic effect because you get a lot of oxygen. Yes, now we're going to cut down blood flow by 20%. And it's also the dreaded ischemic perfusion, a reperfusion injury that we also help to mitigate in those. CROs, very complicated protocol, very rare diagnosis. Nobody follows the protocol, really. You're supposed to be admitted on oxygen, get hyperbaric treatments. I get calls from people who were sent home 3 days later. Somebody told something about it. I've not had anybody that I've been able to keep on protocol. Pretty rare. Idiopathic sudden sensory neural hearing loss. I wake up in the morning and I can't hear out of my left ear. Who knew? Or I don't hear good out of my left ear. Criteria is 30 decibel loss across 3 contiguous frequencies. There's a back and forth as to whether this is ischemic or infectious. It looks like ischemic's winning out. The only therapy that's actually been shown to help is hyperbarics, although they do steroids. So your typical treatment for this is you either get oral or intratympanic steroids, and if you don't get better, you start hyperbarics, but you got 14 days to start. If we don't get it done in 14 days, started in 14 days, we've lost our indication. And the problem is getting through the insurance companies and getting authorizations within our 14-day window. That's what makes this a little bit difficult. The only problem I have with this diagnosis is there's a 65% spontaneous recovery. So I don't know. It's kind of like TPA in a stroke. Was that a TIA and it got better and it was going to get better anyway? Or, did our intervention really matter? And I don't know. I don't have a good way to judge that. But the research right now favors hyperbarics. We do a moderate number of these cases, not too many, but a moderate number. That's it. I'm going to stop there. I know we've got a couple minutes, so real quick, any questions that anybody has, more than happy to answer them here, or I can leave an email address. You can feel free to email me as well if you've got some questions that come up later. Go ahead.
Hold on, let me just give you the mic so you can speak into it.
I'm just wondering about the new dressings that deliver oxygen directly to the wound beds.
Yeah.
Can you comment on that, the effectiveness?
I don't use them to start there. They're expensive, but I know that's an area of very intense research. That is not going to supplant hyperbaric oxygen therapy, and I'll tell you why. The penetration depth of that oxygen is very shallow. You're not talking about a deep penetration. And I would almost liken that to a topical hyperbaric oxygen treatment where you stick your foot in a hyperbaric chamber and you're saturated with oxygen. And the argument is that you get a certain penetration of oxygen into that granular wound bed.
Right.
And that then benefits the same tissues that we've talked about here in terms of enhanced PMN killing. Bacteria don't do as well. Your fibroblasts do better in terms of making collagen when they're enriched with oxygen. There's a number of things that the oxygen does. not going to give you the angiogenesis. That's a cardiovascular procedure. And for the most part, hyperbarics is a cardiovascular procedure. And I'll joke with patients who will ask me about that. And I'll say, unless you can breathe through your foot, and I'm not just to have fun, but unless you can breathe through your foot, it's just not going to be the same thing. The way we oxygenate our tissues is heart and lungs. And yeah, I think that those dressings will have some promise, and I think that they will have some benefit. Are they going to create angiogenesis and stem cell release? I don't think so.
Okay, thank you.
Sure.
Like, be a little bit how blood sugars drop.
I would love to. And I will tell you that that's actually recently had some controversy. So the theory was a yet unexplained model of increased skeletal muscle consumption of glucose in the hyperbaric environment. That was the theory, although no one could actually show exactly how that happened. Recently, there's been some research that says that these are random hypoglycemic events that would have happened anyway. It's just that you're monitoring their sugars, so you caught it. I've done enough hyperbaric oxygen treatments that I'm not ready to sign off on that one yet, because there's certain patients who want to drop 40 and 50 points every time they're in the chamber, and we all know that. We see that, and then we know, well, some people, they'll be like, well, they're at 115, can they go? Yeah, okay, but not that one. Not the one that dropped 40 or 50 points every time. That one's got to get to 120 at least. So I do think there's certain individuals who seem to be susceptible to it. The theory is increased skeletal muscle consumption, but that is a theory.
Well,
what about diving a patient who has radiation necrosis, but they still have cancer? So is it beneficial, or is it more of a risk?
Case by case, and you can make, that's as different as each individual one is. So in broad strokes, number one, first thing you need to know, does hyperbaric oxygen therapy make cancer worse? No. Does hyperbaric oxygen therapy make cancer metastasize? No, that's a done deal. That's been decided. The angiogenesis process in cancer is a pathologic process that's not normal, and that pathologic, not normal process is not enhanced by hyperbaric oxygen therapy. In fact, there's some very early research with cancer patients where they do things like give them a hyperbaric oxygen treatment and immediately give them their chemotherapy agent. And the preliminary data says maybe this is beneficial. Why? Because an ischemic tumor is an angry tumor. Angry tumors want to metastasize. And as they outgrow their blood supply, as they get that central necrosis, they become more aggressive. If you placate them, quiet them down, are they more vulnerable then to the chemotherapy agent? Maybe. That's really early stuff. That is not ready to run with at all, but there is some data out there. Next, if you, and you wouldn't do this, but you've got terminal cancer, you're going to die. I mean, why am I, and I'm not trying to be insensitive, but why are we rushing to try and close a radiation-induced wound when your overall prognosis is terrible? I mean, and you don't really want to spend 2.5 hours a day, during your final days here in our hyperbaric chamber. But there are situations where a wound might be particularly debilitating. Maybe they can't eat and they need to get better nutrition. And if we could heal up some of that mandibular osteoradionecrosis, there are scenarios where you can make that case. But that's got to be done on a case-by-case basis. And I think you need to be very careful when you document, what specifically goals you're after by using hyperbaric oxygen therapy under those circumstances.
Going back to those Wagner tree wounds.
Yeah.
Do you actually send them to get bone biopsies to confirm? You said yes?
It depends, again, on the circumstances. But here's my concern with a bone biopsy. If you had an MRI that sort of showed you where the osteomyelitis was and you were reasonably assured that you were going to do a biopsy in the right spot, that might be worthwhile. A blind shot, because it might or might not be there, now you've introduced a portal to create the very thing that you were worried about, because you've got an open wound and now you've created a pathway directly into the bone. So I treat Wagner 3 presumptive osteomyelitis. I can't always sell that to the infectious disease people in terms of antibiotics, but I treat that as a presumptive osteomyelitis.
So you're saying if it probes to bone in the office,
Yep. Now,
so we don't have to go for surgical debridement and antibiotics necessarily the way that you were saying you have to for the recurrent osteo?
I don't. Now,
Okay.
to be fair, if there's a piece of the metatarsal hanging out and it's exposed and I'm looking right at it, I'm probably going to send that to the podiatrist, have them debride that, get them on IV antibiotics, and then do my hyperbaric oxygen therapy. If I've got a wound that was a Wagner 2 and they decided to go on a walk on the boardwalk with their grandchildren and, wore it out and now it's a 3 and I can probe to bone and we picked it up a week after they, were last here or 2 weeks if they were away, I'm not. If it's just probes to bone.
And the insurance companies?
We're still okay with that. So far,
thanks.
Let's not give them any ideas, but so far we are. Hyperbarics is about to take a 43% cut this year. All year long, they were telling us we were going to be plus 3%, and the guidelines just came out last week, and somewhere between everything they said all year at plus 3, we're about to go minus 40 something. I think it's 43%, which will put a fair number of us out of business. So we're writing our appeals, and we'll see what happens. But it looks, CMS is trying to, at least in our area, drop it by 43%. That just came out this past week, so we'll see how that goes.
To see changes to the wound?
It depends on what we're treating. So, for example, a compromised flap, you come out of the chamber looking better than you went in. It can be that quick with a compromised flap. If we're looking for angiogenesis, again, I'm not panicking at 10 treatments and the wound looks the same. I'm really waiting until around that 20th treatment, and then I should start to see changes around that 20th treatment. If I'm not then I'm not feeling too good about what we're doing, but I give it until the 20. Same with radiation, because it's the same process. We're looking at that angiogenesis. Okay. I could do one real quick if it's fast. Okay, I'll talk to you afterwards. Okay, thank you guys very much. Appreciate it.